Something that's come up several times now. I think, Roger, you had mentioned it briefly as well. What are your retreatment criteria? So, Sean, we saw there in your presentation, it looks like you were retreating eyes kind of every 3 months if necessary. What are some of the things you look at and how do you approach retreatment?
Yeah, so for me, I'll look at the OCT and I'll look at the visual acuity. Those are my two main markers. And so if I see a slight dip in either, but if in my eyes they still remain a candidate for MicroPulse, if there's a reasonable central macular thickness where I think they would respond well if they're under 400, which most of my MicroPulse patients are, then there's really no risk to delivering additional MicroPulse if you get the settings right. So, it's painless, it's harmless, and it's something they could use without getting an injection.
Great. Roger, along the same vein, if there's a patient that has shown a response to their initial MicroPulse, but then recurs, would you find that that's someone that you would then want to retreat with MicroPulse, or would then you switch them over to an intravitreal therapy? I guess the question really is, which patient would you retreat? Like, let's say you try MicroPulse on a patient and they seem to have moderate improvement, but not a lot. Would you then try and give a second dose of MicroPulse?
Definitely. And, I tend not to think of all these therapies as kind of mutually exclusive, particularly in our diabetic patients. A lot of these patients, they kind of need the kitchen sink, so sometimes what I'll do is, I'm not a titrator. The way I titrate my treatment isn't by titrating the power, it's by titrating the number of spots, the location of the spots, and the retreatment criteria, and how quickly I'll retreat. And it reminds me of the way, we don't titrate the Eylea dose we inject into the eye. We always inject 2 milligrams, but we titrate the interval with which we treat them. So to me, the key question when I think about MicroPulse and retreatment is, did I see some response? If yes, I look at that and say, hey, that's a good thing. And if it's an excellent response, but then a few months or 6 months later it recurs, no qualms, just repeating MicroPulse. If it's an okay response, then I go back and I look at my settings and I'll try to document where exactly, I always document the spot size, but where I treated. Did I go straight through did I go through the foveal center, or did I go kind of more FA guided just to kind of where I thought it was leaking the most? And so I'll look back at that and say, well, geez, maybe I should have, been more aggressive. And particularly, I think early on, I was, I think everybody, you're a little timid treating through the fovea at first. And knock on wood, I mean, I've now done it, all the time, and I have never seen a MicroPulse burn. And so you just get increased confidence the more and more you do it to treat right through the fovea. And then the other thing I'll do is sometimes I'll do combo therapy. So, there are some long-acting, ultra long-acting steroids that I think work better once the edema is under control. And so sometimes I'll give an anti-VEGF injection, then I'll say, come back in 2 weeks. And because the retina is a little bit thinner, it looks better. And then I'll apply the MicroPulse. And so sometimes when I've had a suboptimal response, I'll look to say, well, what could I have done differently? To say, let me try, to try and do something a little bit different this time as I retreat.
That's great. Yeah, I'm right along the same lines as Dr. Vusi and Dr. Goldberg. Yeah, I think it's not just kind of retreat everyone, but I think if you think about it a little bit and see what actually makes sense, those are the right patients to retreat, and you retreat them as needed, just like Dr. Vusi presented in his case. A little bit kind of just hopping on that as well, kind of treating over the fovea center. I think that is something that a lot of folks who are first starting get very nervous about, just like Dr. Goldberg said. In fact, one of the questions here is any experience with macular ischemia after MicroPulse therapy. In that study that I first discussed, we actually did fluorescein angiography on all 100 eyes after their micropulse therapy, and we found no evidence of angiographic burns or ischemia after their micropulse therapy. There is a way to do it though. Again, if you are doing 50% duty cycle, that's absolutely a possibility. So you just have to make sure that you are doing it safely, and it is absolutely fine. What do you guys think?
It's interesting because it's not clear what the role of all those, I actually am not sure how much Iridex lets you titrate the duty cycle. I think you can do 10% and 5%, but
yeah, I think it caps at 15.
15.
Right. Okay, so that is like a built-in safety feature, Caesar, to prevent that. And I should give just one other comment. I often will do a single burn like up near the arcade of continuous wave, mostly just to make sure like the laser's working, you know what I'm saying, before I go straight to MicroPulse. So I do like to see kind of one, barely visible burn, somewhere kind of irrelevant to the patient's vision or to the patient's pathology, just to know like, okay, everything's working and whatever, the fiber optics are all aligned, and then I'll go and apply the MicroPulse at my standard settings. I also have never seen macular ischemia associated with the application of MicroPulse. I should say it also doesn't reverse macular ischemia that's there, so it's not like it's a treatment for macular ischemia, but I've never seen it kind of either cause it or treat it.
Great.
Yeah, I agree with Roger. I think you're testing the laser and the focus by putting that extramacular spot, and then Caesar and I, by doing the titration, we're testing the laser as well, because if we're not getting any kind of gray burn, we need to set the power so that we know that there's some uptake. And as Roger, you said in your talk, the red beam has to be in perfect focus in order for it to work. If a patient has too much of a cataract and there's too much scatter of the laser beam, then you're not going to get any kind of response. And then you'll couple months later, you'll see that there was no response to the MicroPulse, and you'll think that it just didn't work for the patient, but it just might be that it wasn't the right time.
One of the things, actually, Sean, I was reminded of is you were talking about, because you really talked not just about MicroPulse, but just about the utility of the Iridex platform having both continuous wave and treating peripheral pathology. And I remember an issue I had with one of my partners, Caesar, this may have been before you joined, but he's like, I was doing PRP and I turned this, I literally had to turn the power up to, I think it goes up to 2000, and he couldn't get a burn. And it was because he didn't realize that the duty cycle is at 5%. So you have to make sure when you're doing PRP and, or lasering a retinal tear, that the duty cycle is back to normal.
That you turn MicroPulse off.
Exactly.
Exactly. Well, that's an interesting question too. So Dr. Vusi, you had mentioned about using focal laser, continuous wave burns for extramacular microaneurysm. So is that something that you still do in conjunction with MicroPulse, or do you just do focal for those areas?
Yeah, it depends on the eye. If there's somebody that has a pretty large eccentric hump with a clear source of leakage, and the fovea is still pretty decent, but then there's scattered intraretinal fluid throughout, that's somebody where I definitely want to seal that area of leakage temporally, extramacular, and then MicroPulse throughout the rest, just to strengthen the heat shock protein for the remainder of the macula. But if somebody's kind of flat all the way across, a few cysts here or there, they just might be a straight MicroPulse person for me.
Got it. I do the same. If I see a juicy microaneurysm, I'm going to hit it with continuous wave burn, and then I'll blanket the rest with MicroPulse, and I think it works really well. On that note, also sort of the combined MicroPulse continuous wave burn, there's an interesting question over here about a patient that has severe PDR and macular edema. I personally have not done this, but either of you guys have done PRP in conjunction with MicroPulse at the time of the PRP therapy?
No, I've never done PRP at the same time as MicroPulse, but theoretically you could. Yeah, just as long as you're aware of what your settings are at the time, and be sure you switch it over to the 5% duty cycle before you treat the macula.
Sure. Yeah.
Yeah, I also have not done that a little bit. I tend to be kind of a one step at a time person. So if there's macular edema and there's PDR, particularly if it's not like a tractional PDR, I usually will give an anti-VEGF injection to acutely control the diabetic macular edema, and then put in PRP to, treat the PDR. And but as we talked about, MicroPulse is a little bit of a slower process, and sometimes if you do PRP, you can make that diabetic macular edema, a lot worse very quickly. So I think having a short-acting agent like an anti-VEGF works well for those cases, and use the MicroPulse really for chronic control of the disease.
Yeah, I agree with Roger there. You want to shut down the impetus for macular leakage much more quickly with an injection like an anti-VEGF before adding the PRP and risk worsening the macular leakage.
Yep, I'm exactly the same as the other panelists. So great. Let's pivot a little bit then to CSR. That's something that both you guys have discussed here, and it is interesting. So one of the questions that came up earlier was, what is the level of fluid that you would comfortably treat with MicroPulse? And my response to the attendee was, I don't like to treat a patient that has very, very thick, dense edema. If they're greater than 400 microns of fluid, I don't think that the laser works quite as well over that area. But CSR is a little bit different. I mean, CSR, some of these patients have dramatic fluid. So do you guys have a level of fluid for CSR, or do you see your patients first day and then start treating? Dr. Vusi, what do you think?
Yeah, I mean, I will let the patients know that they may be less likely to respond as quickly with a large amount of fluid, but I don't see any reason not to treat everybody with MicroPulse, whether it's large fluid or whether it's small fluid, because if you have the right settings, then there's really no risk. There's no downside. You just have the potential to speed up the resolution more quickly.
So you find that the MicroPulse might act a little bit. So in your experience, would you also agree that MicroPulse, certainly for diabetic macular edema or macular edema secondary to RVO, that if it's very significant, it doesn't work quite as well? And
I've had the same experience. Yeah. So okay. For DME, RVO, I haven't had as much success with thick fluid greater than 400 microns, but for CSR I have. And that case that I showed in my talk was a pleasant surprise of how quickly he responded, given where he started from.
Yeah, I'll give a slightly different perspective, which is acute CSR, which is characterized primarily by subretinal fluid. 100% agree. Doesn't matter. Those patients still have a healthy RPE, and you activate the RPE, whether it's, we all, it's a little bit of hand waving, but we know from like animal data that it seems to activate heat shock proteins and kind of rev up the RPE cells, maybe to work better in their pump function and pump out the fluid that's under the retina. And so I think for subretinal fluid in an acute CSR case, there's no limit, 800 microns, no problem, as Dr. Cavusi's case showed. But I think for chronic CSR, where it's oftentimes characterized by, first of all, a lot of RPE, damage, and typically not so much subretinal fluid, but much more intraretinal fluid. And sometimes people call that like sick RPE syndrome. And that's when I find, like, if the RPE has dysfunctioned so much that you're greater than 400 microns of intraretinal fluid, I think kind of activating those like dying RPE cells to try and pump a little bit more and deturgest that retina, that's where I find PDT, where you're actually trying to kind of turn down the spigot rather than increase the drain, maybe works better. And so I find for really thick, boggy, sick RPE and like that end stage chronic CSR, PDT works better. But for, and that's where I think MicroPulse kind of treating early in the disease, because ultimately our goal, frankly, should be to prevent any patient from getting to that end stage disease, period, end of sentence. Like that should be our goal. But that's where I feel like MicroPulse really plays a strong role is before we get to that end stage disease. So anyway, to me, I differentiate by 400 microns intraretinal fluid. If it's subretinal fluid in acute CSR, I think MicroPulse still does well.
I think that's a fantastic point, Roger. I think that historically we have all kind of watched and waited for CSR, and it doesn't really make sense. I mean, us as retina specialists don't tend to just let something go. And especially since these are already sort of patients that tend to be more anxious at the onset, to be able to offer something to them earlier seems to make a whole lot of sense. So that's a great point for sure. So few kind of interesting questions here. So one question was also about using MicroPulse therapy as the PRP for PDR. That's something that I have actually considered and discussed with Iridex in the past. But what's interesting, almost like treating over the fovea, in the beginning, I was very nervous to do that and felt more comfortable over time. This is the same thing. Part of me feels a little bit nervous that I'm under-treating their proliferative disease with MicroPulse PRP. So I personally do not have any experience with that, but I know that people are trying it. Dr. Vusi or Dr. Goldberg, any experience from your end?
I have not used it, but I saw a phenomenal talk with Mark Blumenkrantz and Daniel Palenker, who I know that the Pascal laser is now kind of, and some of that, their pattern treatment's going to kind of fold into the Iridex MicroPulse family. And they were really the pioneers there. And they've showed some pretty compelling animal data on kind of the oxidative demands when you do this kind of MicroPulse or subvisible PRP. And they'll actually often kind of mark with like a visible burn in the kind of squared out. So you can kind of see, oh, this is where I placed, this MicroPulse PRP. But I have not yet done it personally. Usually by the time I'm doing PRP, it's like I'm worried about that patient falling off a cliff or not coming back to my clinic for a year or longer. And so I don't want to kind of take any chances with that patient. So a little bit, I just end up doing the kind of tried and true.
Yeah. What about you, Dr. Vusi?
Here, no personal experience with that, but there are patients, the majority are fine with PRP, but there are some patients who are really reticent to do it because of the peripheral vision compromise. They want to retain all of their peripheral vision. They don't want to lose any of it. That the thought of that really bothers them. And so those are the protocol S type people who would, rather just have multiple anti-VEGF injections to try to regress their neovascularization than have a one-time PRP session. So it definitely, is worth the question, would supplementing with peripheral MicroPulse potentially increase the injection interval for people for whom you're treating proliferative retinopathy?
Totally agree. I think it's definitely something that's probably worth a little clinical series and bringing enough people together. I think it's a very, very interesting idea. So great point for sure. Another question from one of the attendees is, how do we know if the laser is actually taking, because it is subvisible treatment endpoint? I think the panelists have spoken about that a little bit. Dr. Goldberg had mentioned about doing a titrated spot, not necessarily to see what the power is, just to make sure that your laser is working. So I do the exact same thing. I just throw on a laser just to make sure that, the staff haven't stepped on the fiber optic cable and now there's really not an adequate power coming into the eye. So that spot really is just to know what my power setting should be and to make sure that the laser is working. And then, yes, then a lot of it is faith. You just have to sort of believe that things are actually working the way that they are. It's somewhat unsettling, but then when the results come back, it becomes much more comfortable over time. So, all right, we are scheduled till 6, and these are some really, really fantastic questions. So if there are any other questions, we will hang out. Oh, it looks like there was just one more here. So what is the spot size you use? I personally use a 200 micron spot size. You guys as well?
I use 200 as well, yep. And I use a lens that doesn't magnify. Perfect,
yeah. I do the Centralis as well, that does have a slight magnification. I do like the wider field of view, just like Dr. Cavusi. I also do think that the digital Volk series is just such a optically superior lens to the other lenses. And so it really does seem to work better, at least in my, maybe it's just that they've been not in a drawer for the last 6 years being scratched by my partners, but it seems to work better in my hands.
I think that is the answer. I carry my my Mainster focal lens with me. It doesn't get left.
Exactly. That's fantastic. All right.
So, the one other thing I just wanted to quickly mention, both of you guys kind of had mentioned COVID and about, hey, reducing the injection burden. It helps keep patients out of the office, helps keep vulnerable patients out of the office, helps keep the office from getting overcrowded. And I just think it's important to also just kind of quickly mention the corollary, though, which is, you know, I have not been doing anything differently with our lenses in terms of the cleaning protocol on my lens. You know, I think we were all concerned, especially initially, about potentially COVID spreading through the eye or through eye fluids. I do not. I put a proparacaine drop on the eye and then a little gonio in the lens. I do not put like a drop of betadine or chlorhexidine onto the ocular surface. I don't know if either of you guys do that. And I've just been washing my lens with soap and water. We did, just like we put on, frankly, all of our slit lamps, we put a kind of like a plastic shield at the level of the oculars, and that just does create a little bit of protection between the patient and the treating physician. Obviously, we're all still wearing masks. I'm vaccinated. Most of our patients are, but certainly not all of them. And so anyway, it had that side of it has not been a concern for me. Have you had any patients ask you guys about that or express concern in any way?
No, that hasn't come up for me, and I use the same cleaning protocol as you without any issues.
And me as well. That has not come up. Patients don't seem to have that concern, and you know, the possibility of being able to come in fewer times is certainly more exciting to them than any concerns that they have sort of on the actual visit time. So it's a great point. Maybe it is something we think about if we're using a little drop of chlorhexidine on the ocular surface before we do the laser. That's a very interesting thought. It's kind of like giving betadine for pink eye. So perhaps we are being able to help that. So, okay. So really quick, one last question. Any future prospective randomized clinical trials for MicroPulse laser? There are actually several that are happening. I will actually direct that to Joan Stauffer, who is listening in the background. She is kind of the medical guru for all things MicroPulse, and is very aware of current clinical trials. I know that there at least was a clinical trial at UC Davis that was happening with patients with excellent vision in diabetic macular edema. So certainly are clinical trials that are currently happening right now. Okay, and one last question here about treating the polyp. So yes, I do it very similarly. So for polypoidal, and obviously with the Everest data, you do want to try and focus your PDT on the active leaking polyp. What I do is I treat everything, and that's really, I think, for me, a good strong point with MicroPulse laser treatment is it doesn't work like focal. You really want to treat not just the area of leakage, but really beyond it. And so I think that circle that I drew is really kind of telling for what I do. You really want to see where the areas of leakage are, but then you want to treat any areas of abnormal anatomy. So again, if you're finishing with fewer than 200, 300 spots, that's probably not enough. So I will treat the polyp, I will treat the area of leakage, and anything associated with potential RPE dysfunction. Great questions. All right, well, it has been an absolute pleasure. Thank you so much, Dr. Gavusi and Dr. Goldberg, for your time. Again, I feel like I learned more from these sessions than anyone, and it's been an absolute pleasure having all the attendees join us. So if there are further questions, feel free to reach out to Iridex, and they can certainly get in touch with us for any last minute questions. So thank you everyone again for your time, and look forward to seeing you with you soon.